Welcome, everyone. This is Shane from the International Hospital Federation. Thank you for joining us today for our webinar, Incentives from the Authorities on Quality Improvement in Belgium. This webinar is being presented by Dr. Marc Geboers, Director General Hospitals at Zorgnet Ikuro in Belgium. Just a few reminders before we proceed. All attendees will be on mute throughout the webinar. If you have any questions, you can type them in the Q&A tab. We'll try our best to go through all the questions after the presentation. The recording of the webinar will be available on the IHF website next week. We will send the link to your email addresses. Now, it is my pleasure that I introduce our webinar presenter. Dr. Marc Geboers is an established and highly skilled physician with over 30 years of experience in cardiology and hospital management. He is currently the Director General Hospitals of Zorgnet Ikuro, the umbrella organization of Flemish General Hospitals, initiatives from mental health care, and nonprofit institutions from elderly care. Prior to joining Zorgnet Ikuro, Dr. Geboers held C-level management positions in different well-established hospitals in Belgium. He earned his degree of Doctor in Medicine from the Catholic University in Louvain in 1986. He is also an active surveyor for the Dutch Accreditation organization, the Netherlands Institute for Healthcare Accreditation. Marc, thank you very much for joining us today, and we are all looking forward to your presentation.
First of all, I want to thank the IJHF to give the opportunity to talk in a webinar about how we are trying to deal with quality in Belgium, our country. And I'd like to thank everybody who has signed in to hear this story. It's 1 o'clock in the afternoon in Brussels. It's quite hot. It seems to become the warmest day in Belgium in history. We will see, and it may not take us away from what we are trying to do. So, incentives from the authorities on quality improvement in Belgium. How am I going to build this up? First of all, for those who are not familiar with the Belgian state structure, I will give you a very short instruction about how it works, because it's important for the story of how we are dealing with quality in this country. You see it also in the agenda that we are dealing with quality on a Flemish level, and secondly, quality on the federal Belgian level. And finally, we come to the incentives for the hospitals and a conclusion. But first of all, how is Belgium structured? We have one global state, Belgium, which is divided in two ways. First of all, communities and regions. And as you can see, the communities, we have a Flemish community, we have a French community, and they have one part in common, the light blue part you see, that is Brussels, which is as a community integrated in those two. And we have a very small German-speaking community too. If you put it in the regions, we have the Flemish region, the Brussels region, and the Wallon region. And that makes it very complex because each of these communities and regions has its own government, has its own Minister for Healthcare. And as a matter of fact, this is a picture of the eight ministers we have that are responsible for healthcare in all these different structures we know in Belgium. So to bring these people together and to try to make some real work of developing healthcare, it is quite a difficult job. They are brought together in what we call the interministerial conference, where they talk about a lot of things and try to come to a conclusion. But it is very difficult, it's very complicated, and it is asking a lot of time to go on. Just to give some examples of how it works, on the federal level, there is a responsibility that is going to the general hospitals and university hospitals. But at the regional level, Flanders, there is also a group of hospitals which they are responsible for, and are the revalidation hospitals, hospitals with a specific focus on the revalidation activities. And that already makes it sometimes very difficult to bring these things into line with one another. The federal level is responsible for programmation of services, of medical instruments, and the regional levels are for the recognition. For example, recently we have made a programming of stroke thrombectomies, and the number and the standards to which it must answer are defined by the federal level in the programmation. There are 15 for Belgium, but 7 of them are on the Flemish part, and they can put new other standards too before they recognize these 7 institutes. So it's working together, trying to work together, but with own accents, and that's not that easy. Finally, on financing, financing is on the federal level. We call it the budget of financial means, but the financing of infrastructure, that is on the regional level. So there is also a division in what is concerned as the financing of the system. And finally, what we are talking about, quality, is definitely a matter that has to be looked at the regional level. It's the responsibility of the regions to deal with quality, as it is, for instance, also with prevention. But it does not mean that at the federal level, people are just looking at it. They also try to interfere with quality improvement. We will see that sometimes they are trying to put information from one level to the other level, but sometimes it's also counterproductive, and we will come to that later on. So it's quite complicated. It's asking a lot of discussion to come to a line of information, to a line of ideas of how to develop these things. First of all, quality on the Flemish level. We have to go through some history for that. It started back in 1997. I've written it in Dutch because this way you can find it back. It's what we call a decree. It's a kind of a law on Flemish level. And it promoted integrated care, quality care in all that has to do with caretaking. It was very basic at that moment. And as you see in 2003, only 6 years later, it had to be changed in a second law to make it more adapted to the recent evolutions. And what is very important is that in the basic elements you see over there is that already you have, for example, self-evaluation, the introduction of a quality manual, the introduction also of a quality officer, somebody who in the hospital is responsible for everything that has to do with quality, a role that is still going on nowadays, but the content of this function has been changed dramatically over the years, where it was at first somebody who organized self-evaluation and did write the quality manual. It is now a more important role that is played by the quality officer. Also, the role of the authorities was already described at that moment. And we also had at that moment already, at the beginning of the years 2000, the introduction of indicators as an important element. And at that moment, there were 69 clinical indicators that were followed in 12 topics. But as a matter of fact, it was all going very slowly. The development of quality care was not going that fast. And so in 2012, there was an update of the system in which 3 elementary pillars were defined to promote quality in a more pronounced way. And this was accreditation by an ISQA accredited organization, the more profound use of indicators, and the specific role of the authorities by use of an inspection matter. We will go into detail in all of these 3 pillars to define exactly what was meant by it, what was the idea behind it, and how were the hospitals involved, what was their role in every of these initiatives. First of all, accreditation by ISQA accredited organizations. That means that for Belgium, it was Joint Commission International, and secondly, the Dutch Institute for Accreditation in Care, NIAS, which was now founded or finds its origin in the Documentum Canadian system, which was developed in the last years through NIAS in Belgium. We have 55 general hospitals in Belgium and 8 revalidation hospitals. That means that we have 63 hospitals in Globo, and all of these hospitals have adapted to the accreditation cycles not from the beginning, but after a certain time, every hospital has taken the decision to go for an accreditation with an ISQA accredited organization. So there were some hospitals who already started before 2012 with an accreditation cycle. It's about 10 years we are now dealing with accreditation in our country, but it got a boost in 2012 because the Flemish authorities stated that all the hospitals should have an accreditation audit before the end of 2017. They had to complete a first cycle of accreditation before the end of 2017. The route they were using for the hospitals to go to an accreditation was that what before existed as a systemic general inspection by the authorities, by the Zorginspectie, was replaced by the accreditation. And that should drive hospitals into the direction of an accreditation with a more robust accreditation framework, a more robust quality framework, so that could give some impulses to an amelioration of quality. Of course, 5 years is not that long to do this. You know that to adapt it, to develop it in your hospital, to get used to the standards that are written down in the manuals of these accreditation organisms, it's quite a job to do that in 5 years. So a lot of hospitals were not ready by the end of 2017, although a majority got a positive accreditation result already at that moment. And of course, with a cycle of 3 or 4 years in the accreditation, starting in 2010, there were some of the hospitals who were even going at that moment to a second and even a third cycle, and some are already preparing now a fourth cycle. So it was a very strong way of adapting a general framework for accreditation and for quality improvement that was introduced into the Flemish hospitals. Second pillar are the indicators. As I've shown already in the beginning of the year 2000, there were some indicators that were used. Now it was in a more organized way by introducing the Vlaams Indicatorenproject, the Flemish Indicator Project Square for patients and for professionals, which was also resulting in a website where the results of these indicators are published. We will go to that in detail a little bit later. I'm going to show you how it is organized and what you can find over there. But it was a next step in, first of all, adapting indicators in a broad accepted way. What are exactly the indicators we are following, and to make them public. And that was also a second very important step in coming forward with the quality improvement efforts that were made in the hospitals. Which indicators do we find now at this website? These are the indicators that are used at this moment: breast cancer, rectum cancer, patient experience, and some hospital-wide indicators. When it is concerning breast cancer, we can see that all the different steps in the treatment, diagnosis and treatment of breast cancer are coming into view with these indicators: diagnosis, treatment, survival and relative mortality risk, and also very important, the multidisciplinary consult as a sign that working together between the different disciplines in the treatment of breast cancer is a very important indicator. Rectum cancer has been recently added: mortality post-surgery, survival and relative mortality risk. And there has always been a very important stress on the role of patients and the patient experience. And this is found in 2 indicators: patient-friendly websites, where regularly the websites are screened on their patient friendliness, and the patient experience, which is measured by a uniform questionnaire, which is, I think, rather unique, that together with the patient platform in Flanders, a questionnaire was developed so that every hospital was asking the same questions to their patients, and that it was possible to have a good idea about how the same questions were answered in the different hospitals, and the benchmarking was possible. And finally, some hospital-wide indicators: readmission, medication, prescription, hand hygiene, prevention of MRSA, patient identification, and the use of a safe surgery checklist. We'll come back later when I show you the website and the results that you can find there. So it was the next step towards some important indicators. And you can say in the years we have done, this is not that much, but we are busy with developing some more indicators, and I come to that also later. Last pillar, third pillar, was the role of the authorities. In the past, it was the global inspection, systemic inspection of hospitals. It was connected with the recognition of the hospitals. The hospital was recognized for a period of 5 years. And before you can go to a next period of 5 years, you had to pass through an inspection where especially the alliance with law regulation was looked at. But there were also added in the years some quality aspects, but it was clear that it was not a good way of promoting and ameliorate the quality in the hospital. So I had to change to something else, which was the accreditation. But the authorities wanted to stay in touch with what was going on the field. And they introduced the subject of thematic inspections. And some of them have already been done in recent years. Internal medicine, surgical medicine, cardiology has been performed recently. And now they are preparing geriatrics. And in the near future, mother-child, oncology, psychiatry, and dialysis will follow. I'm going to show you how this works. A framework is made. I hope you see now the operation room framework. I give you what's in it. They stress on architecture, on all the staff that's over there, the nurses and the medical staff. A few functional things that are to be done, but also very specific quality-driven things like safe surgery procedure, the preoperative investigations, the handover of a patient on the different moments in an operation room, medication, and the hand hygiene. And it is described in a very detailed way. The standard is given. There is a declaration of what the standard exactly means. If there are perhaps some other questions or other demands related with the standard, they are placed over here. If there is the possibility of giving a number, a goal you have to reach, it's marked here. And then where it comes from finally is declared over here. For example, in this case, it is going about the fact that an operation room should be a closed zone, that everything should be secured in a certain way, and that it should be in 100% of the cases that it should be like that. And it is based on an advice by the High Council for Healthcare. So this is developed for all the different issues I've mentioned, internal medicine, surgical medicine. And that means that after a certain time, you have for all these different things, a really very nice framework based on law, based on good practice, based on what's in the literature, so that in the future you can use this to re-evaluate to see if there is any amelioration in the system, as had already been done on internal medicine and surgical medicine. How are the hospitals now involved in this story? First of all, accreditation is, by matter of its basis, on a voluntary basis. There is no financial incentive from the authorities. That means if you have to pay for the accreditation to the organization, you have to do it as a hospital. You are not compensated for that. It's your own choice, and you have to pay for that. In return, as I've said, there is no global inspection anymore by the authorities, and the recognition of the hospitals, which was in the past only for 5 years, is now for an unlimited period. So you can be sure as hospital that you can go on for a certain time, but this is something, the accreditation, that brings you an added value, not represented in money you get, but in the fact that the authorities are not going to come every so much years to do through examination of the hospital. We see that all hospitals finally participated in the accreditation, and the results of the accreditation have to be declared to the authorities. We had some discussion about the fact that it should only be the yes or no. Are you accredited, yes or no? But the full reporting should be sent to the authorities. That is, has created some discussion because the authorities are obliged to make it public, to give it to the press if they ask for it. And of course, a report that is made by an accreditation organism is mostly an internal document with which you have to work. We have now had this discussion. We are giving the reports to the authorities, and we are trying to find a way that not the complete reports will be found in the press, but we are on good speaking terms with the authorities about that. Another question is, what if you were not ready before the end of 2017? Some hospitals were not ready. Systemic general inspection by the authorities was foreseen, but there has been some talk with the hospitals and the authorities to see what is the planning, how far are you, when will you really have your accreditation. And since most of them are not any further than 2019 this year, we have found an agreement about that. And of course, what's in the future? In our country, we have a discussion if accreditation is the best way to have our quality measured. So we are now discussing what should happen in the future. Is one cycle enough? Should you do 2 or 3 cycles? And also on that item, we are as Zorgmedic Bureau on speaking terms with the authorities. Indicators. Indicators, we have now a very good structure, not in the past, but now with VIP Square, it's working good. Flemish indicator project for patients and professionals, and with a very important voice from the hospitals itself. And it is embedded in a large supervising structure, which is called FIX. It's the Flemish Institute for Quality of Care, which is not only taking care of what's happening in the hospitals, but also mental care, in elderly care, and the general practitioners. And they should bring this together. We have until now no indicators who are going over the borders of the different silos of care, but the idea is to do that in the future, and that FIX should organize this. Indicators are also on a voluntary basis. That means that most of the hospitals are publishing all their indicators on the website. They are not obliged to do that, but of course you must have a very good reason why you are not doing that if, for example, the press or the public is asking why you are not doing that. There is some support by the authorities in data managers. In the past, we only had 2 of them to do this, but was not enough, certainly not. Recently, it has been brought to some more data managers, and we hope that that will give the necessary speed to catch up with the new data we are going to introduce and actualization of the existing indicators. I will give you an idea of how this is published on the website. This is the website Quality Care. You see a list of the hospitals. You can select a few of these hospitals to compare them. We will have, oh, wait, that's a pity. No, I can't go back. For example, breast cancer. And then you can only compare 3 hospitals. And here you see the results per indicator for the 3 different hospitals. Diagnostic process, when you have to decide on the type of breast cancer, and we see the results of every hospital with the goal marked over there. Also the pathology examination that happens, the medical ultrasound or mammography that has been made. And the same things here, you see the multidisciplinary discussion about the patient. And so for each of these indicators, it is marked in a very good way, comparable. And if you are a patient, you can go to these results and try to compare the different hospitals in your neighborhood to see which of the hospitals is doing the best score on that. Finally, on the role of the authorities, hospitals participate in the discussion about the reference framework. What I showed you is always a result of a discussion with people in the hospitals, with different type of people who are involved, specialisms who are involved with this specialty. And they bring this together, so it is really a solid base you have for this framework. It's of course obligatory for all hospitals. It's performed in an unexpected visit by the inspection team of the authorities, and these results are also publicly accessible. There is a publication of the results, the report is made public, and all the different issues concerning infrastructure, for example, but also all the quality elements are brought there together and have a very clear idea about what was found by the inspection. So far from the Flemish part, we have also some quality initiatives on the level of the federal government. And it started also about 10 years ago, 2017, with a specific contract that was made between the government and the hospitals about patient safety. We had 2 periods of 5 years between 2007 and 2017, in which there was asked to do, for example, a measurement at regular intervals of the safety culture in the hospitals, to develop a system of reporting incidents in the hospital with the WHO taxonomy and so on. In 2018 was decided to turn this into a pay-for-performance program. And the money that was foreseen before that for the contract about patient safety was transferred to this pay-for-performance program. It was about €6 million to divide over 100 hospitals. We are now at the level of Belgium, and we have 55 general hospitals in Flanders, but we have 100 hospitals in Belgium. €6 million, to have an idea, the total budget for the hospitals is €8 billion. So you can imagine that we're talking about a very small amount of money, and how can you trigger the hospitals for such a very little amount of money to do really important efforts to go to amelioration of quality. It was divided into 2 parts. There was a fixed part, 20% of the money was given as a fixed rate, and the rest, the 80%, was divided according to the results that were obtained in the indicators that were taken into account. There are, in the budget of financial means the regular way, also elements that directly or indirectly can influence quality. For example, there is a lot of money that has gone at a certain moment to qualitative oncological care, for example, to food, psychological support, and so on. Also to food teams in general in hospital. There are also punishments in the system. For example, you have a financial punishment, readmission between 10 days after these patients are going home. So there are already some of the elements you can consider as contributing to quality, but as a matter of fact, the budget of final means was not made for specific quality amelioration before we had the pay-for-performance system. What is brought into this pay-for-performance system? We are working with a system with points. It was about 100 points, but because one of the pathology indicators, results, for instance, the mortality indicators, are not brought into account and have 0 points, we come to a total of 80 points, which are divided in 55 for hospital broad indicators and 25 pathology. What's in the hospital broad indicators? Some structural elements, 35 points, and the most important there is the ISQA accreditation. It's given 25 points. And that's the idea is that when you are doing an ISQA accredited accreditation, you really bring into your hospital a lot of framework, really standardized framework for amelioration of your quality, really introducing a system which involves also a lot of people who are coming over, you're involved in this, a lot of money you are putting into this, and that when you're doing this and with success, you must be paid for that in a good way. There are also some other things, other labels you get for quality, and as a link with the old system of the patient safety management, there is also something about the way incidents are sent to to the authorities. Also, a very important point stays the patient experiences. We are moving now slowly toward prompts and prems, but at this moment, we are talking about the patient experiences, as I've explained to you in the Flemish part with the contribution of the patient platform. 20 points, a quarter of the points is given to patient experiences, and it is really based on that results that these points are given. Pathology is connected with prophylaxis by surgical interventions, hip surgery and pacemaker surgery, and also some cancer indicators, and this is given 25 points. In the future, when we have very good information from the medical clinical indicators we have with each hospitalization of a patient, mortality will be introduced, and then the resting point, the 20 points, will given to that. We have had some discussion about, for example, breast cancer. We have in our country recognized breast cancer institutes, and we have hospitals who are doing these interventions, but not with a recognition as a center of specific breast cancer treatment. And there was a question asked if not everybody could get these points. The government has decided not to give these points to those who are not recognized, from the idea that if you are not recognized by the authorities, it's very difficult to give points, that's money, to these hospitals who are still doing things for which they are not recognized. So it's a little bit of a point of discussion. We have to clear that out in the future, but it's giving a little bit of difficult questions. What are the further challenges for this pay for quality? Of course, the updating yearly of the used indicators. We have for 2019 now introduced head and neck oncology indicators. Also, the discussion, how are we going to deal in the future with achievement versus improvement, connected with the fact that we have a closed budget of 6 million. That means if you give more to one who is doing a tremendous improvement, those who have already a very high level of achievement will get less money. So we will have to discuss that. How are you going to deal with that achievement versus improvement within a closed budget? And certainly the question, if you want to make this really an incentive to go to amelioration of quality in a substantial way, we have to find extra financial means to bump up this 6 million euros. And of course, do we have the best indicators at this moment to influence our quality in the direction we really wanted to evaluate? Okay, what are now the incentives for the hospitals? First of all, they are surely not financial. You have understood that. Flanders, we have no financing at all. Federal, it's only a marginal budget we have, if you see it in the global context of the budget of financial needs. But what we see is that even with a very small budget for the pay for performance, there is no hospital who wants to lose a single euro. And you have a lot of discussions about the validity, the way the indicators are measured, are presented, if it is correct, if they can make control of it themselves, because they really don't want to lose a single euro. We are in budgetary constraints, so everybody wants to gain as much money of this pot as possible. Another incentive, which is working very good, I think, is the transparency of the results. The website I've shown you, the open government policy, that everything is shown to press, to public, is a very, very strong argument of contributing to amelioration of quality. Of course, also because it's giving some benchmarking, and the internal competition between hospitals is a very strong incentive. Of course, the most important is the belief in quality improvement itself, but we know that you have to take some really touchable incentives if you want quality improvement, to make it a constant way of looking at care and how are you dealing with that. So if I come to my conclusion, within this system over the last 10 years, it is very clear that hospitals have accepted quality and quality improvement as a very important concept. And they also have accepted the way things are used for that. Accreditation, indicators, the role of the authorities, it is acquired. Nobody is discussing this anymore, that you have to do a lot of things at the same time if you want to come to quality improvement. Although the importance is recognized and government is saying this is a very, very, very important way of dealing with the future of our caretaking, little investment until now is made by the authorities, and we should like to ask if it is possible to make it more that it is more touchable really also in terms of money, in rewards you are getting one way or another if you are making really work of this. And the major driving force at this moment, I think, is competition and public disclosure. Perhaps we can say that whatever force finally is driving the improvement of quality, the most important thing is that we are doing all the efforts we can do to improve. And to conclude with Mr. Deming, quality is everyone's responsibility. We have to take care of that. We have to work very careful on it. So it's not a spectator sport. You really have to work on it. So that's my story. I hope it was clear, but of course, I'm ready to answer all the questions you might have.
Thank you, Mark. We'll start reading some questions from the audience shortly. Just to remind everyone that you can send your questions by typing them in the Q&A tab. Here is our first question. In the Flemish approach, there is a concerning issue on the use of indicators as a possibility of cross-check between hospitals. How does this work, and to what indicators does this apply?
Yeah. We have seen that for some of the indicators that are used on the Flemish level, we have a kind of a cross-check that is happening between the different hospitals. Somebody from hospital A is going to hospital B and vice versa. And it is especially because there are observative things you have to do. For example, the prescription of medication, if it is okay, the way hand hygiene is taken into account. And these are the things that are observatory issues, and that is taken care of with a system that is developed in which there is this cross-check between hospitals to make it very clear and as objective as possible.
Okay, thank you for answering that question. We have an audience question. We have a question from the audience here. How is the risk of patient selection addressed when P4P for items like readmissions? Is the government also incentivizing other sectors to support improved primary care and home care to ensure good continuity of care to avoid readmissions?
That's a very good question. There was also a question we got before already about how it is brought together with the other sectors of care. And until now, it is not. For example, when it is concerning the readmissions, there are some efforts to try to develop a system to have a good way of accepting people once they have left the hospital. But it is not institutionalized at this moment. So it is a little bit difficult to have really a good idea about it. But since everybody is touched in the same way, of course you can have some differences between the different hospitals in the way they are dealing with that, and they are making their own, they're dealing with the nurses at home and so on, with the general practitioners, how you accept these patients. So there is a way of doing it, but it is your own initiative you must develop to try to have better results with that. We need really something in which a broader perspective is brought and things are working in a better way together, but we are not that far already. When we look at the VIX story, where also the general practitioners are involved and there are trans care indicators that are developed, perhaps it will be more objective to have some idea what is really happening in a quality way in these transfers.
Thank you, Mark. We have a number of questions. Whether integrated bundled care was incentivized across care providers and settings beyond hospital for specific conditions like hip and knee replacement, stroke, and the like.
Yeah, that's a little bit what I told before. Until now, we are not so good at it. It is the initiative of every hospital on itself. We are now at this moment working with the idea and changing the hospital landscape to more networking between hospitals, but not only networking between hospitals, but also with the primary care around it. And that will give some opportunities to deal with that. It is not at this moment in the system we are developing. I think it's very clear that what I've told you now is really a hospital-centered story, most of it centered on what's happening in the hospital itself. We are very aware of the fact that we have to broaden this, but we have no organized system. There are some tryouts, let's say, some pilot projects for integrated care, which are trying to give an answer to this. We have also something about maternity, which the stay of length is brought in shorter, is made shorter, and there is the need to have some care that is given at home to these people. And so, but it's all at this moment in pilots, in experiments we are trying to do, and we have to learn a lot about it to make it in a better way. And if you really want to organize it for your own organization, you have to do it in a local way.
Okay, thanks, Marc. Another question here. Do you know what the other regions do for quality improvement?
Well, we have some ideas about it. We see that we have a very way ahead with Flanders, but we see that the other regions, Brussels and Wallonia, are catching up with that. For example, we had at the start of the P4 performance very big discussions between the different regions in the country about the role of accreditation in it. And we see that now also the hospitals in the French-speaking part of Belgium are catching up with that and are making their contracts with accreditation organisms. They are also developing their indicators, and we think we can work together on that and stimulate one another. So it's going in a good way. We are seeing that that all the different parts of our country are going in a good direction when it is concerning quality improvement and quality amelioration.
Okay, thanks again. Another question. What are the methods by which you stimulate staff to adhere to the principles of quality?
Yeah, that is not different from other places in the world, I think. You must try to convince people to give them really an idea that working on quality in different ways is very, very important. What we see is that when you're talking about accreditation, people are having the feeling that it is really a paperwork thing. Bureaucratic and so on, while the key message is that you're not doing it for the paper or for the internal organization of the hospital. You're doing this for your patient, for the safety and the quality you want to give to your patient. And that's, of course, the important message you have to bring. But I know from experience in hospitals that it is very, very difficult to convince your staff, and especially the medical staff, that they have to do something more for quality than what they are already doing. Medical doctors are trained in the idea that they are doing the maximum on quality for their patient, but they have to be convinced that there is a certain moment in which they are not longer responsible for everything of what happens around the patient, and that they need structure, frameworks to give real quality. I see that works, but sometimes you need a lot of convincing talks to bring them to that point. And what you see when you have done an accreditation, that you have a lot of people who say, okay, this is something we can understand. We see there's also paperwork and bureaucratic things in it, but the core is interesting. But you have also a lot of people who say, no, this is not what I think is giving us the time or more time or better time to take care of the patient. It's taking us away from our care core business, and you have to work on that, not only with the quality officer in your hospital, but broader. You have your CEO, your CMO, they all should bring this together and talk to everybody who is involved with this, that it is important. And finally, you do this for your patient.
Thanks, Mark. Here's another question. What are the prospects for mental health care?
Yeah, we see that also in mental health care, the idea of accreditation is on discussion at this moment. We see that in hospitals, it's a little bit easier than in the smaller organizations you sometimes see in mental health care. Indicators is a very difficult one because it's not that easy to find really good quality indicators, or at least it seems to be more difficult to have real good quality indicators. But at least what we see now within VIX, where there is also a room for everything that has to do with mental care, people are really searching for the good ways of measuring quality things. And they have to define first what is really giving an idea about quality in mental care. How do we measure it? And how do we measure it in this way that we can see in the future that we are going in a good direction? But at least we have now the structure where we can do this. And I'm confident with the fact that they will find also a way to deal with that. And it will not only be the authorities who are taking in a way with their inspection some ideas about, let's say, fixating people and so on, that they can find it from themselves, and with these indicators they can go in the good direction.
Thank you. Another question. How do healthcare professionals perceive this methodology and its different aspects? Do they support accreditation and/or indicators use?
Yeah, we've already discussed it a little bit. I am convinced that we have seen a major change in the ideas and the way people are looking at it, also from medical staff. When I started, I was before a chief medical officer in a hospital, and let's say about 10, 15 years ago, when you talked about quality, first question was always, you are saying that we are not giving quality to our patient. No, that is not what I'm saying, but we must organize ourselves, as I said, when it becomes more complex, when more people are involved, that we are giving the same quality. That are not really the questions we hear nowadays. What we hear nowadays is more the detailed discussion about the added value of some of these things that are in the systems we are using. And I think when we have a very open discussion after an accreditation organism has gone through an hospital, that there is some added value to it, but you can focus on the, what you have won with such an accreditation cycle, but you can also focus on the things that are not going well, the things that are not adding any value. And there are things that are not adding value. It is not necessary, I think, to write down everything, that you have to register everything. You have to be clever about that. You must be smart is not it's the word that is used for it. So this discussion is more on detailed aspects, I have the impression. So I am really confident, but perhaps I'm too optimistic, that the global idea we have also with the medical staff, that we are going in a forward way on looking at quality is positive. The discussions we have, we must take it seriously. We must try to find an answer to it. We must catch up also with the ideas that are living in the rest of the world about this. But we have made some progress, some major progress in the last 10, 15 years. I'm quite sure about that. And if we can gain again in the next 5 or 10 years, I'm very confident and positive about it.
Okay, we'll have our last two questions. Are there any ideas on governmental level on how to continue and intensify the incentives for a quality culture in the hospitals?
When we take the case of Belgium, we must say no. And that's a little bit disappointing. As I've mentioned during my talk, we are as Zorgnet Euro very much on speaking terms with the Flemish government about how we have to organize or reorganize the triad of accreditation, the role of the authorities and indicators to the future. It's a very difficult question because everybody wants to play its role. That's one. And you have some discussion about the added value after a certain time of specific things like accreditation. Is it giving the same added value the fourth time as it was giving the first time? We have to discuss that. If the government wants to invest more, it's difficult. We have to keep asking it that if they want to take this seriously, they must help the hospitals in that. As I've said, we are in budgetary constraints. Money is a sparse thing. And we have to help hospitals to go further on the way of quality improvement. When we are looking to the federal level with the money question of pay for quality, I think pay for quality is an interesting thing. There's never been proven that it is giving in the long run really better results on quality, but it's a way to stimulate the hospitals, but perhaps the impact will be bigger if the gain you can make in a way you can touch it, as a matter of fact, is doing it good. So our message as an umbrella organization is that we are going to continue to talk with Flanders and the federal level to spend more money on it, to find a way, as a matter of fact, to stimulate the hospitals to go on the path they have chosen.
Thank you, Marc. Down to our last question. Who helps hospitals that are struggling with QI? Is there a central organization that provides support? Does NIACS do this?
There is no central organ, let's say. I have to put it all away. As Zorgnet Curo, we have what we call a quality and safety committee, which is trying to give some guidance to the hospitals. How do you deal with certain problems? To talk also with government. That's something we are doing. What is happening on the field is very different from the different type of organizations. With indicators, it's clear. You registrate. It's done by data managers, and finally it's published. When it is concerning accreditation, you have what's happening within the accreditation organization itself. NIAS is helping, GCI is helping, you have mock surveys, you have proof audits, as they call it in NIAS. So there are a lot of ways of trying to support hospitals in a certain way on their path toward accreditation results. But of course, it's a global thing, and you have a lot of consultancy firms who are trying to make work of it. But I think we are already giving within the regular work from our side, but also from the side of the accreditation organism, to support hospitals as much as possible in their efforts to go on. So, and I think that if you are using that, you're already a bit on the good way toward good results.
Okay, thank you everyone for sending in your questions. If you think of any additional questions later on, you can contact Marc through the details displayed on your screens. Marc, is there anything else you want to say before we end our webinar?
Well, I think the questions are very relevant. It are the questions we are asking ourselves, as you have heard. We have not all the solutions. I think we have made an interesting structure of how we are trying to deal with all quality improvement, but we don't have all the solutions. So every inspiration we can have is welcome to make it a better way of moving forward.
Okay.
Experience.
Okay. Thank you once again, Marc, for that wonderful presentation. And thanks to everyone who joined us today. We will be posting the video recording and the slides on our website next week, and you will receive the links in your email. Also, we have a very quick survey which will be displayed on your screens right after the webinar. We'd greatly appreciate if you can provide your feedback. Thanks again, everybody, and I hope you all have a great morning, afternoon, or evening ahead of you. Goodbye.
Bye.